right, next we have Dr. Emad Rizk, and he is currently, as you may know, the CEO of Verscend. Verscend works with healthcare organizations to use data analytics to help them be more efficient and effective, and I'm sure he'll tell you more about that work. Prior to Verscend, Emad was the president and CEO of Accretive Health, and before that, the list goes on. He was the president of McKesson Healthcare Solutions and a senior partner and global director at Deloitte Consulting. I love these last lines, which is he's also been named by Modern Healthcare numerous times as one of the 50 most influential physician executives and the top 100 most powerful people in healthcare. So we are lucky to have him, and I invite you up.
Are you sure you got the facts right? Yeah. I mean, I'm not sure. Let's see, this is for forward. Well, I'm happy to be here. Good morning. It's interesting as we think about healthcare, because I've been in healthcare about 25, 30 years. I started when I was 5. But when I got into healthcare, I got into it through medicine and trying to help people. And over the last 20 years, I started to think about, why is healthcare lagging in terms of information? Has anyone ever asked themselves that question? I mean, if you think you have a credit card, that credit card, no matter where you go, it identifies who you are. It knows, no matter anywhere in the world, it understands what is in your bank account, how much your limits are, and there's all that intelligence around that. You think about manufacturing. You think about going even to the hotels. When you go into a hotel room, and I travel a lot. I've been to 5 cities by the time I got here, but I was very happy to be here, by the way. You go, they know exactly whether you want a queen bed or 2 twin beds, and all this intelligence. Yet, if you go to a healthcare system or a hospital, they don't have any information. And they're automating. Just think about that. They're automating and they're putting in EMRs. So we sit, at least in our organization, on around 150 million people worth of data, actual data that we analyze on an ongoing basis. When you think about it, and all the EMRs and everything that we're talking about, guess what % of the data that we get is actually electronic from an EMR? 7%. 7%. And by the way, the data inside the EMR is also unstructured data. Sometimes they scan, and it's not digital data. So you start to think to yourself, for 20 years, every single industry has moved on and has become so sophisticated, and yet we in healthcare are a little bit behind. Why? Well, it comes down, believe it or not, to investments. Most of the industries, whether it's financial services or whether it's manufacturing, spend somewhere between 13 to 15% on data and electronics. You know how much healthcare spends? 1 to 3%, right? Now, over the last couple of years, it has become a little bit more disruptive, and I know Christensen, and I've presented with him, and it is the last 3 years, for the first time I could tell you that healthcare right now is beginning to look at other industries and leverage, whether it's cloud computing, whether it's, there are some healthcare organizations, we're looking at Amazon, not to do a commercial for them, but we're looking at their infrastructure and how do we leverage Amazon technology. Whenever you go on Amazon, it knows who you are. It kind of has that intelligence in terms of it. So you think about the fact why all of a sudden healthcare is beginning to invest a lot in data. And it's because of what Brian discussed. It is that movement from fee-for-service, this disruption from fee-for-service to this value-based reimbursement. Now, Does everybody know what the definition of value-based reimbursement is? All right, well, most likely, each one of you will have a different definition of it. It could be called a bundle, which is, you take a bunch of services, in terms of a knee replacement, and you pay one amount for it. Or it could be an episode, like chronic disease. Or it could be a specific part of a CT scan that you've negotiated a price. But what's going to happen, whether the presidential changes will change any of this, it will not. I know Brian, the one area that I might disagree with, I think that we kind of know what the world looks like from Obamacare to TrumpCare. I made that up, TrumpCare, by the way, just so. Most likely, a lot of the things will not change. What will probably change, and this is just me speaking, we got together about a month ago, about 25 CEOs from around the country. Most likely the exchanges that are dying anyway will probably begin to dwindle, and maybe they'll stop that. And probably the mandates, the individual mandates that you have to pay $6,000 or $7,000, because nobody's paying it anyway. They're not. You don't have to pay for the first 1 or 2 years. So that's what's happening, and that's why you see a lot of the insurance companies come out of the exchanges, is that will probably go away. What you'll see is a movement of the Medicaid lives and the Medicare lives more into the managed care world. You'll see more Medicare Advantage, which is, the data has been shown over the last 10 to 15 years that when you do Medicare Advantage versus Medicare elderly that are managed by government, the Medicare Advantage piece always do much better in terms of cost and in terms of outcomes. So anyway, as circling back to all this, what is happening in data? And what I'll talk about today, because I've been talking about this for almost 20 or 25 years, and at one point I actually tried to write a book about how payers and providers can work together. And that was about 10 years ago, I think. And still, I kept giving the same discussions. But I will tell you right now, for the first time, I have seen a change in big data and the leveraging of big data in a disruptive way over the last couple of years in terms of sharing data across providers and payers. So we'll talk a little bit about this. How do we get data historically, this new cloud technology, and but the most important thing to think about here is that data is just it's a process and it's just a tool, but you still have to bring the providers and the payers together, as Brian talked about. They still have to start, that's just going to be a tool, but you still have the consumer, you still have the providers, and you still have the payers that have to somehow begin to work together in a much better way. So right now, if you think about it, we are probably in healthcare very siloed. You have, Brian discussed, you have the payers, right? The Aetnas, the Cignas, the Anthems, the Uniteds. They sit on claims data, just claims data, which is financial data. It is purely just financial data. So it is, you went to the doctor and you had a hemoglobin A1C done. That's it. Or you went to an outpatient center and you had a CT scan. That's it. That's all they sit on. It's just financial data. On the provider side, they don't sit on financial data. They sit on what? Clinical data. So what the providers have is the result of your hemoglobin A1C and is the result of your CT scan. And the two shall never speak. Ever. Ever. They're divorced for life. And the reason that they are that way, it's because the providers do not want to give up their information to the payers, because remember, there's a confrontational relationship that exists between the payers and the providers. And the payers don't want to give that financial information to the providers because, my God, if they had the financial information, it's kind of like, they'll use it against us. There's all these conspiracy theories. However, what changed over the last 2 years is something called value-based reimbursement, and you're shifting risk. So now the providers are at risk, not just for the clinical outcomes, but they're also at risk for what? The financial piece. But they don't have financial data at all. And then Medicare comes up, and Andy Slavitt, a good buddy of mine that's leaving CMS, or has left CMS under the new administration, the government right now is holding the payers accountable for quality and quality outcomes, but they don't have that data. It's kind of interesting what happened. You're now responsible, whether you're a provider, a hospital system, or a large physician organization, or you're a payer, you're responsible for things that you do not have data. Okay? Now let's talk one more disruptiveness that's occurring in the provider world. You know everybody's got an EMR at some level, right? There's multiple EMR organizations that are, selling stuff to the hospitals and to physicians. Do you have any idea how many of these EMR organizations actually share data with each other? 0. 0. They will not do it. Why? Competitiveness. No, you got to go on our system. If you're not on our system, we're not going to interoperate. And that's what has happened over the last year. And then we'll talk about right now what's happening in this cloud computing, because we're not the first industry to actually go through this. The financial industry went through it. Manufacturing went through it. Oh, everybody has gone through it, and they still found a way to interoperate and create that level of data. So these transformative processes or forces right now, and they will increase. Right now in fee-for-service around the United States, what % do you think is fee-for-service versus this value-based reimbursement? How much? 80, very close. Yeah, about 85 to 90% is still fee-for-service. Keep California, you guys are very special here. California on one side, and then sort of Boston, another special place, on the other side. But in the middle, mostly fee-for-service. And when you think about what happened in California and in Boston, it's mostly Medicare, because it was easy to have this prepaid per member per month payment. So what's happening right now is every single piece, every payer is now moving into somewhere between 10 to 20 to 30% value-based reimbursement. And remember, value-based reimbursement will tie financial and clinical. So just to give you an example of what a value-based reimbursement is, you go and you get a knee replacement. You go to your doctor, you go to your orthopedic, then you go and have an MRI, then you go have surgery, there's an anesthesiologist, then there's rehab. We pay for those completely separate right now. The government pays for them separate, and the health system and the payers pay for it separate. In the future, you will have basically $15,000 to do the whole replacement. They'll just give the system $15,000. Physician, outpatient, MRI, everything. But they're not going to cover reinfection. They're not going to cover readmission. They're going to make sure that you do not in any way have another knee replacement in another year or two. So they're holding them, God bless you. They're going to hold them into the outcomes of what that is. That will force the entire data world to have to integrate, to have to interoperate, because you've now created an imperative for them to have both the clinical and the financial data. So the evolution of automation and technology and all of these things, in the old days, you had to actually create this big, massive data warehouse, and you had to physically have it someplace. And then you start to create all of this interoperability. Right now, it's not that way. What we're doing in our organization, as I told you, we set about 150 million lives. We have data on them for the last 10 to 15 years. About 5 years ago, if we wanted to interoperate that and create an interoperable layer, it would have cost us $50, $60, $70 million. Right now, we can leverage cloud computing. We don't even have to own it. I mean, we own it, but we could just rent it from an Amazon, a Google. Believe it or not, this is actually called platform as a service, platform in the cloud. We could leverage that and basically create this interoperative layer, which is what we're doing, that writes rules. Literally just say, I want to know where Emad Rizk, I want to know all the information on him in all these databases. And these rules, they go in and they extract all the data that's associated with me. You know how much that's going to cost instead of $60 to $70 million? $3 to $5 million. That is what's happening. There is now further technology that will allow that level of interoperability. Now, Brian, you mentioned something that's interesting is the consumer. When you look at how much we spend right now as just in healthcare, we're about maybe $3 trillion. And out of that $3 trillion, and this is going back a little bit into policy and payment. So out of the $3 trillion, a lot of it is in government, a lot of it is in health plans, and about $200 to $300 million is out of pocket. All of us, we paid that out of pocket. Your co-pays, you know, your deductibles, all of that. When you go to 2020, and we become about $5 trillion, the out-of-pocket for all of us is going to be somewhere around $600 billion. So we just, us in this room and in the country, we have now become a completely brand new industry that is data hungry, that is not going to just go to the doctor and say, yes, sir, yes, ma'am, I'll do that. No, they will go in because it's now your money. We are going to triple what our current payment is. That consumerism is the same thing that drove the other industries into that interoperative layer. When you go on and you look at whether it's a Google or what's that other one, Travelocity, and you compare, you know, hotels, you will now be able, you want data to know, is this the right doctor? Is this the right hospital? Is this the right network? And they're going to have to collect that data. So now you've literally, as a consumer, forced the provider to collect financial data to present it to you. So these disruptions, and they're financial, economic, and basically business disruptions, will cause this disruption in data. So the payers. All the payers right now have been mandated over the last 8 years during the previous administration to create something called an MLR. You mentioned the medical loss ratio. So the medical loss ratio right now is at a certain percent. If you do not spend that much on medical loss, you will have to give it back to the recipient, the consumer. And so that has caused a lot of problems in the way that they are connecting and using data. So when they stratify their organization and they stratify their membership and they try to find out how much at risk they are, and with all the actuarials, they realize right now that this influx of 30 to 40 million people that are uninsured, that are coming into the exchanges, they're smart. They have data. That's why what's happening right now is they're all going out of the exchanges. The reason they're going out of the exchanges, they already did the data. And they understand these are high-cost patients. and they're not going to be able to compete on a price level. And you now have Anthem, Humana, Aetna, I believe, I don't know if Cigna has done it. Has Cigna done it yet? They've all pulled out of the exchanges. Huh? Not yet. Not in. Oh, really? So then everybody's out. Basically, everybody came out of the exchanges. So you're seeing this death spiral of the exchanges. But right now, so what the payers did in realizing that they're going to be at risk, they are now beginning to partner, as you're seeing, with providers. They're beginning to shift. That's, again, the economic piece. They're shifting their risk more to providers and to consumers. Employers are doing the same thing. How many people saw their out-of-pocket go up over the last 8 years? Everybody. Yeah. I mean, that's basically what's happening. It's all around shift, and it's all around data, but it's incomplete data. It's only financial data. So the payers are going to begin to force this to occur. Now, let's look at what's happening in technology. You can now use the cloud, which we could not do it before. We could use the cloud. When we go to the cloud right now, there actually is automated processes. I'm not sure if you're aware of what that is. So they already have processes that is already automated in the cloud that when we put the data in, we follow, they help us with what that process is. So as an organization, the way we collect data, the way we use data, the way we create reports, these reporting and performance analytics, we have to create them. They're already up there in the cloud. Literally, they're up there. Salesforce.com. All the tools are in the cloud. I mean, for sales. They're beginning to use that. And you're beginning to see the entrance of Microsoft into health. You're seeing Google get into health. You're seeing Amazon is just hired a big healthcare person to try to help them. So for the first time over the last 1 to 3 years, you are seeing now this consumerism that existed in all the other industries create a process and an automation for healthcare. And for anyone that's thinking in this room about creating and building an entire infrastructure from the ground up that'll take 3 to 4 years, and it's just horrible to do, and it takes so much money, start looking at all of the different cloud computing organizations out there. They literally have the processes automated. You don't have to build it if it's already built. It might cost a little bit more, but at least it gets you across the hurdle much faster. The other thing that they're doing is there's a company that two companies that we're beginning to use that actually recognize this thing called natural language. So a lot of stuff, as I said, remember before with the EMRs, only 7% of the data is coming from EMRs. The other stuff, we're still getting scanned data. We're getting we ask for someone's medical record, and they get scanned or they get faxed to us. Well, now there's tools that actually look at this natural language and digitize it for us. So we could look at notes, and remember, even notes that are on an EMR, a doctor that just scanned, and you know how horrible our signatures are. A doctor just did one thing, and then that could get scanned in terms of what the drug is and whether they're on hepatitis C medication or not. All of that gets digitized. So that technology is out there. Again, first time, and for the what you're seeing in healthcare is people saying, okay, we could start using other industries to help us. So we come to the empowered consumer. Every single disruption, I think, Christian would say the same thing. And I had spent time with him talking about this. And he believes that the disruptions that have occurred across all the other industries was driven by an empowered consumer. Literally an empowered consumer. So in 2020, all of you will be $600 billion worth of spend in healthcare. You know how big that is? I mean, the insurance companies is 1.1 billion, 1.1 trillion. I mean, you're almost that big. So the empowered consumer, you will now, they will tailor everything to you. That's why you're seeing all the commercials from Humana and Aetna. And even you're beginning to see these big healthcare systems come to you. You will have, as you make decisions in the future, which will be your out-of-pocket is, I don't know, $8,000 to $10,000 a year. Let's just say that. You will need to understand which provider are you going to pick. Do you know why? That's going to be important because each provider that you pick, your out-of-pocket's going to be different. Completely different. Because that's going to be what they call a tiered network. It's my wife, sorry. She's like, I heard, Margaret told me that your time is up in 5 minutes. I got it. Sorry, Margaret. I'm done. Okay, thank you. So if you think about it, you will have data in terms of each physician, each hospital system, how they're performing, what the cost is, what the reinfection rate is, what the readmission rate is, and you will be able to get all that data as the consumer. And you will, and what they will do, what the payers and the providers will do, is they will make your out-of-pocket, this is the benefit design. The benefit design will be if you go to hospital A, B, C with physicians, you know, X, Y, Z, your out-of-pocket is only $10. And if you go to the other one, your out-of-pocket is $20. So basically, the consumer is going to push this as much as possible. I'm almost done. All right. Oh, thank you.